Hi, my name's Leigh Dodkins. My student number is S1806106. And today I'll be talking about increased intracranial pressure, or ICP as it's otherwise known. So before we start, we need to learn the basic anatomy of the central nervous system. It consists of the brain and the spinal cord, and protected by the skull, the vertebra, the cerebrospinal fluid, and three membranes, the dura mater, the arachnoid mater, and the pia mater. It's contained within the brain is cerebrospinal fluid, or CSF. The CSF protects the brain and the spine from bolts or jerks, such as in an accident. So the cerebrum is the larger part of the brain containing the nerve centre. It controls sensory, motor activities and intelligence. The outer layer consists of neuron cell bodies, usually called the grey matter, and the white matter consists of axons, basal ganglia, and they control motor coordination and stimulus. The cerebrospinal fluid is a clear, colourless, transparent tissue present in the cerebral ventricles, which is where this red line shows you, the spinal canal and subarachnoid spaces. The blood-brain barrier controls which solute enters the cerebrospinal fluid. This diagram shows you the amount of space contained within the skull. So the brain tissue takes up most of the space. That's 1400 mils, arterial blood 30 mils, venous blood 120 mils, and the cerebrospinal fluid 150. So what is intracranial pressure? It's the pressure contained within the skull, including the brain tissue and the cerebrospinal fluid. Any alterations to this will cause increased intracranial pressure. A theory proposed by Munro Kelly states an escalation in the fluid in one of the components of the skull will cause a change in volume to the other, thus causing a dynamic equilibrium. Arterial blood that enters the brain needs a continuous outflow of venous blood to make room. If this cycle doesn't occur and something doesn't exit the cranial compartment, the intracranial pressure will increase. So some causes of ICP: cerebral edema, encephalitis, which is swelling of the brain, meningitis, too much fluid around the brain, a head injury, aneurysm, rupture, stroke, intracerebral hemorrhage, bleeding into the brain, or a tumour, whether it's benign or malignant. So maintaining ICP levels, the body has its own mechanisms of doing this. It's measured in mercury, millimetres of mercury, and at rest it usually sits between 7 to 15 for a supine adult. It can alter slightly for short periods of time due to positioning of the body or head. Sneezing, for example, can cause the ICP to increase, although it will return back to its usual homeostatic balance. Any changes that may occur in ICP are generally linked to volume changes in one or more areas of the cranium. ICP greater than 15 millimetres of mercury is referred to as intracranial hypertension. Focal ischemia can occur if ICP is higher than 20 millimetres of mercury, and global ischemia is present if ICP is above 50 millimetres of mercury. So 3 stages of intracranial hypertension is an increase in ICP, which is the first warning sign. ICP then increases and exceeds the critical amount, creating the intracranial hypertension syndrome. Compensatory processes may no longer be able to prevent this acute stages from occurring. So what is intracranial pressure? It's caused by a rise in pressure around your brain. It may be due to an increase in the amount of fluid surrounding your brain, or an increase in ICP can also mean that your brain tissue itself is swelling either from injury or from an illness such as meningitis. Increased ICP can be a result of brain injury, or it can ultimately cause brain injury. So what makes it important? Well, elevated ICP is the final shared pathway that leads to death or disability in most acute cerebral conditions. It is also potentially treatable. The two major significance of increased ICP are brain shifts or brain ischemia. Cerebral perfusion pressure, or CPP, is a calculated difference between the mean arterial pressure and the ICP. So when intracranial volume changes, a compensating mechanism takes over. Compensation is limited by intracranial space occupied by fluid components. So this little diagram shows you the increase in intracranial volume against the intracranial pressure. When equilibrium occurs, when the pressure within the cranial is normal. So where the first red circle is, compensation up to a point will occur should pressure from one constituent increase. If this compensatory supply is exhausted, pressure increases and brain shifts may occur and result in herniation. So pressure compensation. The mechanisms for compensation are few. It is restricted by the short interval that is available and by the quick change between the normal ICP to the pathological ICP. It depends on the event that occurred and the speed of the occurrence. It remains limited due to the fixed cranial volume. There are two mechanisms, their efficiency is high. An increase in the cerebrospinal fluid reabsorbs 1 to 200 mL an hour, or a decrease in the fluid contained in the functional tissue area due to reabsorption of the interstitial fluids. The progressive increase in volume will eventually lead to decompensation unless therapeutic intervention has occurred. So this diagram is death spiral of uncontrolled ICP elevation. So as you can see, it starts with brain inflammation and edema, which then leads to a rise in elevation of the intracranial pressure, leading to brain hyperfusion or lack of oxygen. And then the cycle continues unless the intervention is maintained. So the neurological signs of decompensation include consciousness, either loss of consciousness, either partially or fully, vegetative disorders, or injury of the cranial nerve. Cushing's triad is a late sign of ICP. It's the body's way of compensating for an increase in intracranial pressure, resulting in irregular respirations, bradycardia, and systolic hypertension. So increased intracranial pressure can cause, some of the symptoms may be changes in loss of consciousness, impaired eye movement, vomiting, headaches, increase in blood pressure, which leads to a decrease in pulse rate, and the respiratory patterns change. Children are easier to diagnose. They usually have bulging fontanelles, which will be visual, cranial suture separation, and increased in head circumference, and they may have a high-pitched cry. So I've now written 3 questions regarding intracranial pressure, 2 multiple choice and 1 short answer. Question 1, at rest, ICP levels should be maintained at A, lower than 7 millimeters per mercury for a supine adult, B, there is no resting level, C, between 7 to 15 millimeters of mercury for a supine adult, or D, above 15 millimeters per mercury for a supine adult. Question 2, Cushing triad is a late sign of intracranial pressure. What are the 3 symptoms you should look for? A, tachycardia, diastolic hypertension or normal respirations. B, regular heart rate, regular blood pressure or irregular respirations. Or C, irregular respirations, bradycardia or systolic hypertension. Or D, there are no changes at all. And the short answer question is, what is ICP, and discuss compensated and non-compensated ICP. I'd like to take the time to say thank you for listening, and